Can you guys see the slides okay?
Yes.
Thank you guys so much for this opportunity. I look forward to speaking with you all today, and I'll leave some time at the end for questions. So as Nicole already mentioned, today we're going to talk about neuromodulation. What are the treatments that use neurostimulation for epilepsy, and how can they help you? So we know that epilepsy is not a benign disease, as many of you know that, but you live with it every day. And in fact, epilepsy is one of the most common neurological conditions affecting 1 in 26 people. We know that it has no geographic, social, or racial boundaries, and it affects people of all ages. Frequently, it's associated with other comorbidities, not just seizures. It can affect your everyday life. It can affect your relationships, your driving, your education. So when we think about the treatment for epilepsy, what do we think about? And so that's going to bring us into neuromodulation today and options for patients. So if you or your loved one is a patient that has been diagnosed with medically refractory seizures, or seizures that have not responded to 2 or more medications at adequate doses and continue to have seizures, then the question would be, what next do we try? So there are medications, but there's also surgery and neuromodulation options as well. So the first thing we ask ourselves as providers is, if a patient has medication-resistant epilepsy, what else can we provide them, given that they have failed multiple medications that continue to have seizures? So the first thing we ask, and even thinking about surgery, is, can your seizures be localized to one spot? Do we know where they're coming from? If we don't, then vagal nerve stimulation or DBS, deep brain stimulation, would be an option. But what happens if we can figure out where they're located? Well, if we can figure that out, how many foci do you have? How many places are seizures coming from? If it's only coming from one spot, then we'd wonder, is it safe to take that out? And would there be low risks to the patient? Could it be curative? Would you be willing to have that? And if so, then we would recommend potentially resective surgery, where we take out tissue, or ablation, where heat is used to take out the tissue. But if the answer is no to any of those questions, that's when we would think about possible neuromodulation. And that's where we would think about either the responsive neurostimulation system. And the reason why that is helpful is because that gives us EEG data and potentially would help us realize that maybe you are a surgical candidate. However, when we talk about neuromodulation today, we'll be talking about the responsive neuromodulation or responsive neurostimulation system and the vagus nerve stimulator. And we'll talk about that these can even be used in combination. So first, let's talk about the vagal nerve stimulator. How does it work? So it's a pacemaker-like device that controls seizures by sending a signal, an electrical impulse, up the left vagus nerve in the neck at scheduled intervals. So that means, as the provider, we will tell the device to go off, let's say, every 5 minutes for 30 seconds. And what's happening is it's sending a signal up the vagus nerve to basically try to initiate electrical activation, or we call them action potentials, to modify the electrical communication in the brain. We don't know exactly the mechanism of action, but what we know is that there's neurotransmitters in the brain, and their release is changed. And ultimately, what we do is we desynchronize the firing in the brain. So seizures actually are this synchronous activity. So there are cells firing together, growing together. And basically, with neuromodulation, we try to disrupt that synchrony and desynchronize the network, or the EEG or brain waves, so that they can't continue to generate a seizure. So basically, as I said before, the VNS, or vagal nerve stimulation, sends pulses through the left vagus nerve up to the brain at regular intervals. When you place a vagal nerve stimulator, it's a short outpatient procedure that typically lasts 1 to 2 hours, and you go home the same day. The vagal nerve stimulator was approved in the United States in 1997 for use as adjunctive therapy in reducing frequent seizures. And so adjunctive means, in addition to medications. It's currently approved in patients 4 years of age and older for partial onset seizures that are not controlled by medications. And we do use it in generalized seizure disorders as well. And the VNS tends to become better tolerated and more effective over time. And so here you can see that seizures reduce over time, and that continues at least 10 years after the vagal nerve was placed. So you can see if you go all the way up to 10 years, that on average, the seizures are reduced about 75% of the time. So seizure frequency was significantly reduced by 75%. Again, this is a mean or average. We know that the vagal nerve stimulator has had over 20 years of patient experience worldwide. So it is approved internationally, and over 120,000 patients have been treated, including over 33,000 children. There have been over 133,000 generators implanted, and reimplantation rate, which means how many patients decide to get it replaced after the battery depletes, is 77%. The VNS therapy has many benefits. It prompts fewer and shorter seizures over time. It has shown improved quality of life, including mood, memory, and attention. And it actually has an FDA approval for treatment of depression, regardless if a patient has seizures or not. It can lead to fewer healthcare emergencies and costs over time. And it's also been shown to decrease sudden unexpected death in epilepsy in long-term follow-up. Because ideally, if you're reducing seizures, you're reducing the risk of SUDEP. It's also shows decreased seizure intensity and severity. It shows better recovery after seizures, so patients might recover quicker or have, as I said, less intense seizures, less intense post-ictal period or shortened post-ictal period when they're tired. It has no drug-related side effects, and it can be used with medications and other treatment options. The profile, again, it has no known interactions with medications, no reported systemic neurotoxic effects, no rash, impairment, bone marrow suppression, no worsening of cognition. If anything, we'll show you it even may improve some cognition. And the typical battery lasts anywhere from about 5 to 10 years, depending on the settings. And I have seen patients have batteries that last even longer on low settings. And this is just showing you quality life improvements are seen as early as 3 months after the device was implanted. And that quality of life improvement improves over time. So you can see the blue is 3 months after implant, and the purplish pink is about 12 months after implant. And again, you can see improvements in alertness, post-ictal period, seizure clusters, verbal skills, mood, academic achievements, and memory. And less than 7% of patients reported worse or much worse outcome in any single measure. Now, with the vagal nerve stimulator, you're also given a magnet. And what that magnet does is it allows on-demand stimulation. So if someone is having a seizure, they actually can make the device go off right away by swiping the magnet over their chest. So it may stop the progression of the seizure. It may help with seizure recovery time. So it could stop the seizure in its tracks, or it could shorten the seizure, or it could shorten the recovery time. It can help you determine if your battery is depleted. So if you were to swipe the magnet and the patient doesn't feel anything, that might let the patient know that the battery is starting to deplete over time. And overuse is unlikely, because what happens is that after the device goes off, it goes into a refractory period and cannot fire. So it actually has safety mechanisms in place. And so you cannot give continuous stimulation. And we know that continuous stimulation can damage the vagus nerve, and that's why these safeties are put in place. Side effects of the vagus nerve. So the vagus nerve is the 10th cranial nerve. It supplies sensation to part of the ear, the tongue, the voice box, the throat, and motor impulse to the vocal cords, as you can see here. So we know, as I mentioned before, that there's no common systemic side effects that we see with drugs. However, the most side effects associated with vagal nerve stimulator include things that occur only during stimulation and generally diminish over time. And they may be diminished or eliminated by even adjusting the parameter settings. And they can be even controlled by use of the magnet, where if they put the magnet over the device, they can turn it off if it's bothersome. And so you can see here, the purple is 1 year, the pink is 2 years, and the black is 3 years. So patients sometimes complain of hoarseness, again, when the device is going off, cough when the device is being titrated, paresthesias or tingling, and shortness of breath more often when they are exercising. And as you can see, if you look at year 3, most of these have diminished over time and are negligible. Also, with a vagus nerve stimulator, you can get an MRI, both a 3 Tesla and a 1.5 Tesla. And so this is just showing where you can get MRIs. So mainly, almost anywhere you need to. It's just an area in the chest where you can't get an MRI, but you can still get an X-ray, you can still get ultrasound or other things if you need imaging in that area. Now, how do we program the vagal nerve stimulator? So we start low and go slow. And in adults, especially if it's a new implant, we'll implant the device and then we'll wait 2 weeks after implant. And this is really so that patients can heal from the surgery, and it's easier to determine if there are any problems, if it's due to the surgery or the actual VNS dosing. And output current and magnet are initially scheduled or put at 0 so that the patient would not feel any stimulation until after that 2-week period, where they will come into their provider, and then we will start titrating up the device. So this is the dosing protocol we use. So initially, the patients come in, and after that 2-week period, we'll put the output current at 0.25, which is milliamps. It's very small. And then we'll take over 14 weeks to titrate the device. So we have the patient come back every 2 weeks to make small increment changes. And obviously, depending on each patient, if a patient's uncomfortable with any of the stimulation, we can slow down this titration. If they're doing really well, we can speed up the titration. And we also can halt along this if we feel that we've already gotten maximal benefit, or if the patient doesn't tolerate a higher stimulation. But you can see here that basically we have a normal mode, which is when the device is typically going off, a lot of times, every 5 minutes for 30 seconds. We also have something called an auto stim mode, which I will go into now, which monitors heart rate. And increases in heart rate are thought to be associated with about 80% of seizures. So now the device can monitor heart rate quicker than we could humanly respond if someone were to have a seizure. And then lastly, we talked about the magnet, which is almost like an extra rescue that can be swiped if the patient has a seizure during that time that the device is potentially off, to make sure that it goes off in concordance with the seizure. So again, we'll have frequent office visits every 2 weeks for the first several months to track response and adjust parameters. We'll increase that output current at increments of just 0.25 milliamps, once or twice a visit, depending on how the patient is doing, until we get to optimal response. We always adjust the tolerance. So some do not tolerate output currents higher, and so we will adjust that and basically schedule and titrate according to each individual. An output therapy goal is to reach about 1.5 to 2.25 milliamps, because that's thought to be the sweet spot for the best response for the device. Now, as I mentioned before, we're going to talk about heart rate monitoring. So there's new advances in technologies. And so this is looking at heart-brain connection. So seizure activity in areas of the brain that regulate the autonomic system can impact the heart rate. And as I mentioned before, about 80% or 82% of patients with epilepsy experience a rapid heart rate increase associated with the seizure. And sometimes it's something that we see even before we can see scalp changes on EEG. So it allows the device to sense that increased heart rate and basically send a stimulation right away to try to stop the seizure as soon as possible. And so here, this Aspire is what it's called. It was this heart rate detection was approved by the FDA in 2015. It's the first and only VNS therapy that provides a responsive stimulation to heart rate increases that may be associated with a seizure. So again, what will happen is some people might worry, well, what happens if I exercise or go upstairs, the heart rate increases. But this is actually monitoring for sudden increase in heart rate above baseline. Like typically when you exercise or you're going upstairs, you'll get a gradual increase in heart rate, but not a sudden increase above baseline. So it detects a rapid sudden heart rate increase or rise, and then delivers automatic stimulation. It has customizable parameters to meet the patient's needs, and it works in conjunction with the other two modes, the normal mode, which is always going off every 5 minutes for 30 seconds, and that magnet mode where a patient or caregiver can give an extra dose if needed. And so sometimes people will ask different questions about the 106. And sometimes they'll say, well, I have nighttime seizures, and so I can't use the magnet. And so the Aspire model or the 106 model is good because you don't need to know when your seizures are coming because it automatically senses the heart rate. And sometimes people might say, well, I can't apply my magnet because I don't have a warning. Again, you don't need to necessarily know the seizures coming because the device will automatically sense for increase in heart rate. And then a magnet will be, you don't need to worry about the magnet because it's more heart rate monitoring. And then I don't have enough time to apply my magnet before my seizure. Again, this is for patients where you don't need to use a magnet. You don't need to be the one that is stimulating the extra, I apologize if you can hear my daughter in the background. You don't need to be the one that actually is initiating that extra treatment because the device is going to automatically sense your increase in heart rate without you having to do anything and send a stimulation. So the Sentiva or the model 1000 is the newest model that came out in 2017. And this model allows you to actually have day-night programming. So that means that you can have different programming depending on different times of day. So for example, I have a patient who has choir practice at 6 p.m. every day. And so at that time at 6 p.m. or 5:45, I can make it to automatically diminish some of the settings so she doesn't feel anything, no disruption during that time. Also, if a patient has sleep apnea, sometimes it will lower settings at night. The 1000 model also allows for scheduled programming. So that means that the generator gradually and automatically increases therapy without the need for return to clinic. So that means that in patients that don't drive and it's hard for them to get to clinic, especially when they have to come to clinic that every 2 weeks during that initial titration period, we actually they don't need to come to clinic and we can schedule those incremental increases to be done remotely every 2 weeks. And we can even schedule a virtual visit during that time when it goes up, or it's something that we figure out a time with the patient and it will just automatically go up at that time. So it allows customized settings that may allow the patient to achieve a therapeutic range and sooner, because especially if they're limited by being able to get into the office. So providers can program multiple different therapeutic steps even during one office visit. And as I said, it can be done and scheduled remotely. So how can the VNS help and how can it help you? So patients who continue to have seizures after brain surgery may benefit. So what this is showing patients who had surgery in the past and continued to have seizures. And what it showed is if you look here on the left, this is looking at percent of seizure reduction and the percent of patients that had seizure reduction. And then on the right, you can see quality of life outcomes. So on the left, it's actually showing that these are patients, again, who had failed surgery in the past. And despite the surgery not working, were given a vagal nerve stimulator, which showed an increased reduction of seizures and an increased reduction, in the different patients, sometimes greater than 50% reduction, sometimes greater than 75% reduction, and sometimes greater than 90% reduction in seizures. And again, this improves over time. And then also, as I pointed out already on the right, you can see quality of life, and you can see that that also improves over time. And again, that relates to kind of post-ictal tiredness, alertness, clusters, mood, verbal ability, memory issues, all of those patients did much better in those areas as well. So that concludes the vagal nerve stimulation portion of the talk. And now we'll move on to the responsive stimulation. And then at the end, I'll open it up for questions on either device, both devices, or just about neuromodulation in general. So the responsive neurostimulation system, the RNS, is a treatment option for drug-resistant epilepsy. So again, that's what all of these are for, as we talked about before. So the RNS currently needs to be implanted in comprehensive epilepsy centers or level 4 epilepsy centers. And so part of that is because the RNS, the leads get placed in the brain. The vagus nerve stimulator, the lead was placed just around the vagal nerve in the neck, but here we're placing something into the brain. And so the level 4 comprehensive epilepsy centers, they offer epilepsy surgery and neuromodulation devices, as well as intracranial implants to figure out where the seizures are coming from and where to place the leads of the device. So now we'll talk about the RNS system for drug-resistant focal epilepsy. So how does the RNS system differ compared to the other options for drug-resistant epilepsy? And so here we talked about, resective surgery as an option versus laser ablation versus neuromodulation devices. And here, for simplicity's sake, I just have the VNS and the DBS categorized together versus the RNS system. So when you talk about targeting the source of your seizures, we know that the resective surgery and laser ablation does that, and the RNS system does that as well, because the leads to the RNS system are put in the brain where the seizures are coming from. As far as preserving brain tissue, resective surgery and laser ablation is taking out tissue, but the neuromodulation devices, all three of them, preserve brain tissue. No brain tissue is removed. As far as adjustable therapy, again, with resection and laser ablation, you can't adjust what you've already taken out, but with all three neuromodulation devices, you were able to adjust therapy. And lastly, in looking at recognizing and responding to brain activity, so I'm not talking about heart rate activity, but responding to abnormal brain activity, the only device that responds to abnormal brain activity is the RNS system. So, who's a candidate for the RNS system? So if you are 18 years of age or older at this point, if you've tried 2 or more anti-seizure medications and you still have seizures, if you have focal or partial onset seizures that come from 1 or 2 areas in the brain, and if you have frequent seizures that impact your quality of life, then this would be an option that you'd want to talk to your providers about. And so your epilepsy team will first conduct testing to determine where your seizures are coming from. And so if the seizures are coming from one spot that's safe to take out, then and you are amenable to having tissue removed, that's typically what we will recommend, because that often and you can't take that area out, that's when the RNS system is valuable, because it is a reversible therapy and it does not involve the removal of any brain tissue. And the primary risks associated with the RNS system are those related to most surgical procedures, such as risk of infection or bleeding. The rate of infection is very low, similar to other implant procedures, and you would talk to your doctor about this. The neuromodulation device, the RNS itself, fits, and you can see it in the diagram, the top diagram, it fits into a small titanium tray and does not touch the brain. Its leads has actually has 4 wires, but it can only hook up 2 of them. So 2 of the wires, if you actually want to put it in 4 different places of the brain, 2 wires can kind of be capped to use for future potentially, and 2 wires can be connected to the device. And those wires are placed where the seizures are thought to be coming from. And once placed, the neurostimulator is actually flush with the skull, so no one can see it, and you can't either. It typically, for placement, takes, you're in the hospital about 1 to 2 nights of the hospital stay. The newer model, which came out also several years ago, it's called the RNS 320, is estimated to last about 8 years. And most comprehensive epilepsy centers are implanting this model. The replacement procedures are typically outpatient procedures that last about an hour or less. And so how does the RNS system work? So what it does is it actually monitors your brain activity 24 hours a day. So it's constantly monitoring for any abnormal activity. And then if there is abnormal activity and it basically knows what to look for based on what you as the provider and the engineer that works with the NeuroPace company set as an abnormal pattern for each individual patient. So each patient's seizures are different from another, and we set, as the providers, set the pattern to recognize. And so if there's an abnormal pattern, the device will recognize it and respond to your specific seizure pattern within milliseconds. Ideally, it's trying to respond to stop the seizure from spreading, and ideally stop it before a patient even feels anything clinical. And then it records that data and reports it over a secure cloud to your doctor, your provider for review. And as I mentioned before, every person's seizures are personalized. They are unique to that person. It's almost like a thumbprint. And so your doctor or your provider personalizes the device for you by programming it to recognize your specific abnormal brain patterns. And then over time, your provider continues to adjust and fine-tune the device to pick up your abnormal patterns quicker and quicker. And again, try to stop the seizures before you even feel anything clinical. The RNS shows sustained seizure reduction that improves over time. It's been implanted in over 3,000 patients to date. It's available at most comprehensive epilepsy centers, and there's over 160 comprehensive epilepsy centers. It's broadly covered by most insurance and government, public and private insurance. Results seen with the RNS system. So patients will report fewer seizures and more living. So there was a real world study that was published in 2020 that showed that the RNS system patients reported experiencing fewer seizures. They reported a median seizure frequency reduction at 3 or more years of 82% reduction in seizures. So that was at about 3 years or more. They also reported more seizure-free days. So 1 in 5 patients reported being seizure-free at their last checkup. So it was about 20%, 19%. It was also shown to lower sudden unexpected death in epilepsy as well. So you can see a trend with the neuromodulation devices. So again, SUDEP, or sudden unexpected death in epilepsy, is a death that happens that is unexplained and could be related to a seizure, or actually could be related to effects of seizures over years. We don't always know why it happens. But the RNS system has shown that there's a significant reduction in SUDEP with the RNS system. There also is quality of life improvements. So there's been shown to be improved health and wellness. So in a clinical study, patients with the RNS system reported significant quality of life improvements with improved physical health, improved mental health, less seizure worry, improved cognition. And clinical trials show no chronic side effects that we commonly see with medications. So they're not reporting any chronic side effects with the device. So in living with the RNS system, it's important to note that stimulation is usually enabled at the first or second office visit, but you shouldn't feel the device working at therapeutic settings. And we actually, in every office visit, we will test the stimulation to make sure that nothing is felt before the patient leaves the office. So you go home with a laptop. So at home, you use a handheld wand, and you can see a picture of that at the bottom of the screen, attached to a simple remote monitor or laptop to collect information and transfer it to a secure website that your provider can review and look at to determine your treatment progress and further modifications that are needed. At first, your provider visits might be around once a month, and then over time, they're about once every 3 months. And patients who have the Model 320 neurostimulator can actually also receive MRI under certain conditions. So there's a button actually that you can program that says MRI mode for this model. There are resources for both neuromodulation devices. So the NeuroPace website, www.neuropace.com, can help patients find an epilepsy center that implants the device, since with RNS, it's only a level 4 epilepsy center, but with vagal nerve stimulators, it can be placed at any epilepsy center. It doesn't necessarily need to be a level 4. There's a peer forum where you can talk to your peers. They can set you up with someone who has the device to answer questions. And again, that's both for VNS and RNS. And there's different resources and literature. There is social media, and there's also contact information and ability. These two pictures right here are patients that have had the device that have volunteered to be ambassadors to talk to patients who are considering the device. So is neuromodulation therapy right for you? So if you're still having seizures after trying 2 or more prescribed medications at adequate doses, then the next thing would potentially be to think about other options that are non-pharmacologic or do not require medications. And so again, that might be surgery or neuromodulation. And I think of surgery and neuromodulation as 2 different things. I think of surgery as going in and potentially removing tissue. Now, neuromodulation, there's also a surgery to place the device, but no tissue is removed. And it is a reversible procedure. If you're ready to try another treatment method to gain access or gain control of your seizures, then neuromodulation could be right for you. And depending, when we think about neuromodulation, the vagal nerve stimulator is the least invasive. So sometimes that's the first step that people will take. Also, we know that the vagal nerve stimulator has a FDA indication to treat depression. So if I have patients who are having uncontrolled seizures and they have severe depression, and they may not want to have any type of surgery or implantation into the brain, then the vagal nerve stimulator is typically where I go first. And then if the vagal nerve stimulator, reduces their seizures partially, but not enough, that's when I may go to another neuromodulation device like the RNS, the responsive neurostimulation system, and or discuss if they are potentially a candidate for surgery. Again, sometimes they look like they're not a candidate for surgery because they may have seizures coming from 2 different areas, or the seizures may come from an area that can't be taken out. Because again, as I said before, it's important for speech or motor or vision or memory. And so if that's the case, if you can't have any tissue that's removed safely, that's another reason why the RNS can be helpful. And sometimes patients may look like they're having seizures coming from 2 different places. So for example, 2 different temporal lobes. And then when the RNS is in and they're back on their medications, because maybe this was discovered when they went to the epilepsy monitoring unit, medications were taken off and it looks like they're having seizures in 2 places, then they get an RNS placed, they go home, the RNS is 24/7 monitoring abnormal activity, they're back on their meds. Then it may turn out that the seizures are only coming from one side when they're on their medications. And then they may be a surgical candidate again, if that's something that you're interested in. And so there's a lot of options. Also, if the time it takes you to recover from seizures is interfering with your ability to live your life, and medications, you've tried multiple medications, they haven't helped, they're affecting you cognitively, there's side effects, or even if medications aren't working for you, as I mentioned previously, that's another time where neuromodulation might be right for you. Or if you're on medications and they may be helping, but they're causing a lot of side effects, which is impacting your life as well. Then again, the thought would be, what other options are there that don't involve medications or pharmacy, and something that doesn't have the same side effects as the drugs that we use every day in patients with epilepsy. Also, if you're worried about missing doses of your current seizure medication, neuromodulation basically has built-in compliance. So with the vagus nerve stimulator, as I mentioned before, you're setting it so that it goes off every 5 minutes for about 30 seconds, regardless of whatever you're doing. If we're setting the heart rate, it's going to monitor your heart rate and any sudden increases in heart rate without you having to do anything. So there's really no voluntary part of managing your seizures that you need with the vagal nerve stimulator. With the RNS, you do need to download your data so that the provider and field engineer can look at your data to make changes. But once those changes are set, then the device still will automatically monitor that abnormal activity and send a stimulation to try to stop the seizures. So again, it's still going to go off regardless of what the patient's doing. And there's no active voluntary control needed in actually giving the stimulation. Again, for the RNS, you do need to download your data so that your providers can look at the data and use that data to further titrate your device. The other thing that the RNS data does, so the RNS, as we know, it treats your seizures, but it also gives us a lot of information about what your seizures look like, what time you have your seizures, do they all happen at night? If we add a new medication, it might tell us within 2 weeks if that medication is working. If we want to stop a medication, it might tell us if that medication was needed. And I've actually seen the RNS help patients identify triggers. So there was a patient who every time he ate rice or a high carb meal, he'd have a seizure. And so we started keeping a diary and the date and time when he would eat certain things or drink certain things. And then we could see with the data that he would have a seizure then. And when he changed his diet, the seizures reduced. And so it can help kind of modify behavior and other things that can help to treat seizures again that have nothing to do with medication. And lastly, if you're not a candidate for intracranial surgery, then neuromodulation could be an option for you. And again, neuromodulation, depending on the type, actually almost every patient is a candidate because some neuromodulation devices like the DBS and the VNS are for generalized or focal epilepsy. You do not need to know where the seizures are coming from. The RNS, as of right now, ideally you do need to know where the seizures are coming from, but there are some centers that are implanting the RNS in the thalamus, which is kind of a relay station for seizures in patients where it may not be clear where the seizures are coming from. So basically all the devices are able to be used for many different types of seizures. So if the answer is yes to any of these questions, you may benefit from neuromodulation therapy.